Yeah, so in recent years and recent decades, we've made tremendous advances in both diagnosing and treating rheumatoid arthritis. You know, about 15 years ago, the CCP lab test came about, and that certainly helps with specificity for diagnosing rheumatoid. The other point I would make is the idea that we really focus on diagnosing RA early and treating early, sometimes aggressively, when we make that diagnosis, because we know that those that we treat early and diagnose have the greatest likelihood of doing well long term in terms of prognosis and that type of thing. I think it's, the guidelines help us to recognize the importance of early diagnosis, early treatment for sure. Yeah, so we know that women are more predominantly affected by rheumatoid arthritis, but generally the onset of disease can be very similar for both men and women. But for the condition itself, people as a whole may present differently. Some people may have a sudden onset of symptoms, the signs manifest, and the diagnosis comes. Others, it's a more insidious onset of symptoms over time. And it makes it a little harder to diagnose, but we should always have that high level of suspicion. And when someone presents with inflammatory joint disease, or joint symptoms, I should say. So biologics, this new class of medications over the last couple of decades, 2 decades almost, have really made a sea change in the way we approach the treatment of rheumatoid arthritis. Traditional disease-modifying medications such as methotrexate, plaquenil, sulfasalazine still have a place, but biologics, for those who don't get good disease control with methotrexate, or these combination medicines, have really been a great add-on or a great tool for us that we can use to treat rheumatoid arthritis. In some ways, they're cleaner perhaps than the traditional disease-modifying medications, but they are still powerful medications with immunosuppressing properties. And so we have to monitor them closely over time. Because there are many types of biologics or small molecules now, we're very selective in how we choose them based on a person's comorbidities and a patient choice as well. We want to maintain quality of life for any age of patient, but we want to have someone maintain the things they both need to do and want to do over time. So again, early treatment to stop and even slow down joint damage from happening is tremendously important. Encouraging people and persons to maintain activity and being as active as they possibly can, realizing there will be some limitations based on symptoms and such. But our treatments, both pharmacologic and non-pharmacologic, can really help us to help encourage. It's early in life, oftentimes, maybe in the 3rd or 4th decade of life, that people may present, even though RA and other inflammatory types of arthritis can span the lifetime, but it's during those periods of time when rheumatoid often can present itself.